Electronic health records contain a patient's health history, including visits, complaints, diagnoses, medication history, lab results, imaging, and treatment plans in one electronic format. EHR also contains patient safety data precautions. In 2009, as part of the HITECH Act, the government set aside $35 billion as financial incentivization for healthcare institutions to adopt EHR. Part of this rollout plan included milestones for data tracking and system adoption called meaningful use. Nearly 96% of U.S. healthcare organizations are EHR compliant. Even though EHR seems to be the standard now, it still poses challenges to healthcare such as cost, workload, interoperability, standardization, and IT health security. One of the barriers to adoption is cost. Adopting any new system does not come cheap, especially when it must have so many specific capabilities that are able to support a vast array of medical services, data, and security. Part of the incentives put forth during the government mandate to adopt digital health records was aimed at helping to offset the cost of implementing EHR systems through financial rewards for meeting specific milestones. Quote, the Michigan Center for Effective IT Adoption estimates upfront and yearly costs for implementation range from $15,000 to $70,000 per provider, according to Reisman. A teaching case study estimated that for a 12-physician practice with multiple specialties, it would cost $225,000 upfront with $54,000 in annual maintenance. This cost also does not include the human capital for training, seeing less patients during the learning curve, and necessary hardware to support the EHR system. Workload is another concern of many physicians, as this increases with EHR documentation, reporting, and meaningful use tracking. While EHRs may be more thorough than a paper chart, inputting the multitude of data into the right areas, along with documenting sometimes very complex treatment plans and notes, doctors have been experiencing burnout much faster. One study compared the age groups of physicians and how EHR affected their face-to-face time with patients and number of weekly visits. Interestingly, it concluded that physicians under 36 actually see less patients weekly after adopting EHR than older physicians. However, in the end, the statistical differences actually evened out, which led the study to conclude that adopting EHR has, quote, basic EHR use had no statistically significant impact on overall physician visit volume per week at all levels of the volume distribution. However, another study found that physicians spend approximately 33% of their work hours performing direct clinical work and 49% completing clerical tasks and interfacing with the EHR. For every hour of clinical work, physicians spent 2 hours on clerical or EHR-related tasks. Another challenge is interoperability. Interoperability is the sharing of data across multiple EHR platforms and is perhaps the biggest challenge that faces EHR use. While a free market helped create many choices of EHR platforms from which providers can choose, one thing seems to have been left out of consideration for all of them: sharing data. If a patient sees multiple providers or specialists, if these doctors are not within the same hospital system, their EHR data may not transfer. This means that patients may have incomplete health histories, have to spend additional time giving test results and history to new providers, or that clinical staff must take additional time to scour, print, and email or fax a patient's health history to a new provider. Not only does this create a point of frustration for the patient, but having gaps in a patient's health history could prove dangerous for the patient and opens up the provider to liability if something crucial is missed. Usability is another challenge faced with implementing an EHR system. Usability of an EHR system is crucial to the success of adopting it into a practice fully. Because each practice, size, culture, workflow, demand, and area of medicine can vary so greatly, having a one-size-fits-all approach is nearly impossible. A small primary clinic will need a much different EHR than a large city's trauma center in a hospital. Many EHR systems are customizable, but this also can create issues with tech support, staff training, updating changing workflows, and finding limitations that would still require creative workarounds. A study in 2015 looked at the effect of EHR systems and connectivity. This study showed that younger physicians liked using an EHR system because it helped them find all the information in one place and prompted appropriate data input. However, more seasoned physicians complained that the EHR flow sheets were lacking and that finding all the necessary data to truly know their patient stressed their cognitive abilities and affected the quality of care they were able to give to a patient because they felt like they didn't know their patient as well as they should. Within this study, a nurse also mentioned that knowing how to input the data into the EHR was not the same as knowing how to interpret the data for clinical reasoning. IT safety is also a very important piece to ensuring EHR success. Protecting data and patient information is paramount to protecting the doctor-patient privilege and HIPAA. Tracking data can be helpful for public health issues, chronic diseases, and patient success outcomes, however, must be protected from those who do not have the need to access a patient's records. IT safety concerns are also tied into interoperability to guarantee that patient information is protected while being transferred to or accessed from other healthcare organizations. Meaningful use was a set of standards enacted by the Affordable Care Act that requires physicians to track specific data in order to be reimbursed by CMS and not penalized. Meaningful use standards were rolled out in 3 levels to ease providers into compliance. Because each EHR system had to be certified at each level in order to receive reimbursements, many physicians were not meeting this standard. However, some smaller providers found that the penalty imposed for not reaching certain meaningful use levels was worth it due to the time and cost associated with completing a level. In 2015, the Medicare Access and CHIP Reauthorization Act helped ease some of the payments by essentially combining meaningful use with the new merit-based incentive payment system. In conclusion, the biggest issue facing EHR after over a decade of required implementation is still interoperability. While experts have been trying to figure out the best way to combat this, the vast size of the U.S. healthcare system and the lack of standardized practice models within that system make it very hard to implement a one-size-fits-all platform. Health IT security is also a key component to making interoperability a reality. Protecting patient data while opening up the access to patient information across multiple avenues means health IT security will have to be ironclad before true interoperability can be accomplished. Patients and providers seem to be comfortable with the EHR workflow as commonplace now. However, there is still much room for improvement to make this technology as safe and efficient as possible as it continues to mature.